Hi guys, let's now talk about superficial and deep bacterial infections in regards to the skin. So in today's video, we're going to be discussing about what is known as bacterial infections or SSTI, meaning soft tissue and skin tissue infections. SSTI, soft tissue as well as skin or skin and soft tissue infections, alright? Now, when we talk about soft tissue, and really specifically skin infections by bacteria, we really refer to the fact that a part of the layer of the skin is being affected, all right? And whichever layer of the skin being affected, you can typically categorize it into two terms. Whether it is superficial bacterial infection of the skin, or it's a case of deep bacterial infection of the skin. So in today's video, we're going to revise together part of the bacterial infections that are superficial, as well as the bacterial infections that are deep. And we're going to go further detail as to what they mean by superficial and what do they mean by deep. And typically before we start, we just want to mention, typically any bacterial infection, especially in the skin, it could either be a primary or secondary. Maybe one of the reasons you have a bacterial infection in the skin is maybe you have a scratch in your skin or some sort of crack in your skin. So that allows the bacteria such as Staph aureus to enter inside the skin and cause an infection. Or maybe you have a secondary infection, let's say pneumonia for instance, and it was complicated by bacteremia, and throughout the blood as the bacteria travels, it can go through the skin and cause a bacterial infection. So it could be from the outside or it could be from within. Regardless, most of the cases is due to cracks within the skin or trauma or basically an injury to the skin that allows the bacteria to enter through and cause an infection. And of course there are many numerous types of bacterial infection that might occur. The most common ones typically is according to the epidemiology according to the age group. One of the most common may be impetigo. We'll come to that shortly. And there are some that are mild, and there are some cases that are very severe, according to the penetration of the skin, according to which layer of the skin is being mostly affected. All right. So now let's talk about bacterial infections. And before we go into each one, let's get a general concept. Any bacterial infection, especially of the skin, will be characterized by a skin lesion. And it varies a lot. Maybe it's a papule, maybe it's a vesicle, maybe it's a bulla, right? Maybe it's a case of an erythematous rash, erythema, a lot of erythemas. So, especially in the form of erythematous rash. There's a lot of skin lesions that may manifest in a lot of bacterial skin lesions. However, a lot of them tend to follow the same signs and symptoms, meaning whichever skin lesion is in a bacterial infection, it tends to be itchy. Most of them are itchy. A lot of them are tender or painful in touch. A lot of them are red or erythematous. A lot of them are edematous, filled with fluid, as well as skin lesions that with or without may be accompanied with fever. Maybe the patient may have fever as a systemic symptom. Maybe the patient may have lymphadenopathy, especially in the neck. Maybe the patient may have chills or malaise or headache. So the patient may come in any bacterial skin infection with a skin lesion that may be itchy, that is tender, that is red, that is edematous, and with or without systemic symptoms such as fever, headache, chills, and malaise. Okay? And if you notice, a lot of these descriptions, they match the description of inflammation. And that's typically what occurs with bacterial skin infection. There's a case of innate immunity playing it here. There's a lot of cases of neutrophils that are increasing in their number, and they're associated with acute inflammation. So vasodilation, erythema, hotness, tenderness, all of this matches, and you'll definitely see this in most of bacterial skin infections. So keep this rule in your mind. There are some exceptions, but mostly, almost all of them follow the same concept, okay? Now that we get an idea about really the type of, or the description specifically, of whichever skin lesion that we might see in a bacterial skin infection, let's go revise one another the anatomy of the skin one more time. So if you remember, the skin is divided into layers, right? Let's say this is for example, a cross-sectional view of the skin. And the skin, as you know, is divided into epidermis, dermis, subcutaneous layer or subcutis layer, fatty layer, as well as the fascia, and then finally the last thing is what? Skeletal muscle, like of your forearm, alright? So that's what your skin is divided into these following layers. And if you remember the epidermis, the outermost layer, those are the ones that contain your keratinocytes from previous videos, as well as your corneocytes. They make up your physical barrier, this one right here. Your dermis layer, this is the one that basically acts as your connective tissue. Those are the ones that contain your blood vessels and your nerve supply and mast cells. And most importantly, they're the ones that contain your glands, sebaceous and sweat glands, that may line up a hair follicle. Now, hair follicle, the base of it starts at the dermis and extends towards upwards like a tree root or like a beanstalk. It extends towards the epidermis, like this skin right here. All right, and it's going to be very important when we talk about certain bacterial infections. All right, so if you remember the dermis contain hair follicles. Every hair follicle lies within a cavity known as the follicle, and each hair follicle starts at the dermis with its base and then protrudes upwards towards the epidermis. And then you move on down below. You have the subcutaneous layer, or the subacutous layer, or the panicula, which is characterized of adipocytes. All right, as well as if you go further down below, you have the fascia and the skeletal muscle. The fascia is subdivided into superficial and deep fascia. It doesn't really matter, but if you want to, when we go later on to certain infections, they will be divided into superficial and deep fascia. And then underneath the fascia contains what? It contains none other than your skeletal muscles. Okay, so I want you to revise with me quickly the anatomy, because now we're going to be discussing basically certain bacterial infections that target specific sites in the skin and thus give different clinical presentation, especially when it comes to the appearance of a skin lesion. Okay? So now that we've got that out of the way, now let's talk about each bacterial infection. Let's start with the superficial ones. Now we have a case of a superficial bacterial infections, meaning we have a case of a superficial bacterial infection that mostly occurs or infects one specific part of the skin, and that is the epidermis. So whenever you hear the term superficial bacterial infection or the term superficial in regards to skin infection, they mostly mean the epidermal layer, all right? The superficial layer, the outermost layer, all right? So this is going to be the most site being affected here. And we have examples of superficial bacterial infections here. For example, we have a case of impetigo, we're going to talk about that, and we have a case of folliculitis, and we're going to talk about that as well. Now let's start with impetigo or impetigo. Now impetigo is a superficial bacterial infection, and it is something that we should know very, very well, because impetigo is not just any bacterial infection, it is the most common bacterial infection of the skin, especially in children. So you see this crown right here? This crown represents that this impetigo is by far the most common bacterial skin infection out of everything, especially in children. And since we're talking about children, what about the epidemiology? What does impetigo mostly affect? In which age group? Well, mostly the preschool age children. The children between 2 to 6 years age group. And that's not a surprise, because this infection, by the way, which is most commonly caused by Staph aureus, is very, very contagious. This is a very contagious bacterial infection. It is very easy to spread, especially among school children or preschool age children that don't adhere to hygiene, or their parents have poor hygiene. So it's very, very easy to spread, especially when you're in a crowded condition, or you don't wash your hands, for example, or you have a case of a patient who has a bacterial infection like pneumonia and he hasn't been treated. So it's very, very easy, regardless, especially with poor hygiene or in a crowded condition, to have impetigo. It's very contagious, especially among 2 to 6 years age children. And impetigo has a cause, which is a bacterial cause. And there's two main organisms we want to focus on impetigo. The most common causative agent of impetigo is Staphylococcus aureus, which is a gram-positive cocci, which is coagulase and catalase positive. And that's a bacteria that can release its toxins. Besides Staph aureus, the second most common is Streptococcus, or let's say Staphylococcus pyogenes, or S. pyogenes, let's just say, all right? So S. pyogenes, also known as Streptococcus pyogenes, or group A Streptococcus gas, basically this is another common causative agent of impetigo that is the second most causative agent, all right? And it can cause a specific type of impetigo in clinical presentation that we'll come to shortly, okay? But by far the most common is Staph aureus, followed by pyogenes. Now, Now, the Staph aureus and the pyogenes, like any other bacteria, it could come through poor hygiene or crowded condition, and once it reaches the skin, it could cause a numerous of skin infections. By far the most common is impetigo, alright? Now, impetigo is not necessarily a severe thing. It can resolve itself spontaneously, but at times, you might try to give this patient treatment if need be. But let's talk about impetigo. What is the clinical feature in a child, let's say, especially in the face? What is the clinical presentation of impetigo? Well, the clinical features of impetigo is going to be divided into three things, alright? Non-bullous impetigo, which is by far the most common clinical presentation. Non-bullous impetigo, number one. Then number two, bullous impetigo. Then number three, and the rarest form, erythema, or also known as deep impetigo. So the clinical presentation is according to these three types. So we're going to discuss each one, starting with the most common type, or the most common clinical presentation, which is non-bullous impetigo. You see, in non-bullous impetigo, what happens here, alright, I'm going to draw by the color blue the area that's being affected in impetigo by Staph aureus most commonly, which is right here in the epidermis, alright? So what's happening here exactly by the letter I, alright, I for impetigo, is that the Staph aureus will release its toxins and it's going to affect the nearby cells. And this is obviously going to attract the attention of neutrophils, okay? And neutrophils going to come in, it's going to induce inflammation, and you're going to have, as a result, an infection. And an infection in the skin will lead to a pathological change in the skin. And this will lead to the development of skin lesions, right? So the skin lesion here is going to be developed in the epidermis initially with all this edema, and remember, edema and redness, all this acute inflammation that's going to come with neutrophils that are recruited. Well, the skin lesion that's going to be presented here is going to be form of a papule at first. So you're going to have an itchy, tender, red edematous papule with or without fever and lymphadenopathy in non-bullous impetigo, alright? So you're going to have a papule, and if you don't remember a papule, it's a raised lesion less than 1 cm, okay? Now this papule, alright, once it develops, it might be filled with fluid, alright? This papule, this raised lesion, once it's filled with fluid from constant edema, it might convert itself into a vesicle. So from a P goes to a V, it can convert into a vesicle. And as a vesicle is a raised lesion less than 1 cm that consists of fluid. Another name for a vesicle may be a blister. Just do not be confused with the term. Blister and vesicle are the same thing, but blister is a general term. So let's go back to the point in hand. Papule may be the first primary lesion in non-bullous impetigo, which may progress into vesicles once it's filled with fluid, because papules don't have fluid, but in vesicles they do, so they become a fluid-filled sac. And you see this vesicle now, that's commonly seen especially around the face, especially on the corner of the mouth, or especially in the eye, or near the eyes, or in the forehead, or in the nose. You see these vesicles, when they accumulate with fluid, at some point they rupture. These vesicles would rupture, and when they rupture, the fluid that leaks out eventually dries out. And this dried exudate will give the form of a secondary skin lesion, known as a C, that is crust. So there will be the presence of a crust, especially in the angle of the mouth and in the nose, especially in the face of a case of a child, and this crust that develops as a result of a rupture of this vesicle, this dry exudate, this crust will take the form of a honeycomb appearance. Meaning what? Meaning the crust will look like a honey-colored. It will be a honey-colored crust or a golden crust. So you will see, like in this picture or in this drawing right here, you might have a child that may present to you with fever, with lymphadenopathy maybe, with chill, with malaise, and you examine his face and you'll see the presence of multiple golden crusts or multiple honey-colored crusts, especially in the angle of the mouth, in the nose, all over the face, and also other areas as well, such as the lower limb or the upper limbs and the trunks, but especially in the face. So once you see this clinical presentation, you will think to yourself, most likely diagnosis, impetigo, because this is a characteristic or hallmark feature of impetigo, okay? So this is a case of non-bullous impetigo, okay? Now let's look at the second most common type of impetigo presentation, which is bullous impetigo. Now, what is the difference between non-bullous and bullous? From the name. You see, in non-bullous impetigo, there was no formation of a bullous. A bullous is a raised lesion more than 1 cm. Basically, a bullous is a type of blister. They're the same thing. When you compare a vesicle and a bulla, they're the same thing. They both carry fluid, they're both raised lesions, they're both fluid-filled sac. But a vesicle is smaller, it's less than 1 cm. But a bullous, it is more than 1 cm. And these two, vesicle and bulla, they join to a group known as blister. So when people say blister, they might mean vesicle, they might mean bulla. But if you want to be more specific between a vesicle and a bulla, the only difference between the two is that the bulla is larger. So the key difference between bullous impetigo and non-bullous impetigo is that in bullous impetigo, there is the presence of a bulla. You have the presence of basically a papule, let's say P, that basically eventually is filled with fluid. It becomes a vesicle, and let's say this vesicle eventually accumulates with so much fluid that it enlarges. It becomes more than 1 cm, and it gives the form of a bulla. Okay? It gives the form of a bulla. Now, this bulla, like a vesicle, is prone to rupture. And if this bulla is to rupture, it will give what? A secondary skin lesion rise. You see, when a bulla ruptures, the fluid will leak out, it will dry off, and this dried exudate will appear in the form of a crust. And this crust right here, it will not appear golden colored or honey colored. No, the crust in non-bullous impetigo will appear as brownish crust. It will appear as a brown colored crust. Alright? And this one you're going to see it most commonly not in the face, you'll see it in the extremities, in the trunk, in the upper limb, and in the lower limb. So you'll see here maybe the presence of a brown crust and some unruptured bulla, like this case right here. Okay? So this is the key difference between a bullous and a non-bullous. So a patient may come to you with the same presentation as we said. An itching, tender, red, edematous bulla with or without, or let's say in this case with fever and lymphadenopathy and arthralgia and all that. But this time we have a case of a bulla in the extremities, or not in the face most commonly, but in the extremities. And when they rupture, they give a brown colored crust, okay, in some of them, all right? That's pretty much it for non-bullous impetigo. For bullous impetigo. And typically, the causative agent that commonly causes bullous impetigo is S-pyogenes. S-pyogenes, they tend to be the ones that most commonly cause bullous impetigo and no other type. All right? Staph aureus can also cause it, but also it's most commonly S-pyogenes. Okay? Now that we finished with bullous impetigo, let's now go to the third most common type. And remember, up to this point, these two types of impetigo, they involve the epidermis, okay? They are basically involving the superficial epidermis, especially around the stratum corneum layer, the outermost layer, okay? Now let's talk about the third and the rarest type of impetigo clinical presentation, known as eczema. Eczema, or known as deep impetigo, here in this type of impetigo, no. This one involves the involvement of the epidermis as well as the dermis. You see, what's happening here is that, unfortunately, in some cases, a patient could have a lesion, all right? A patient could have a lesion here, just like in bullous and non-bullous impetigo. He might have a lesion like a papule or like a bulla. And let's say this lesion, unfortunately, it does not localize within the superficial epidermis. No, this lesion extends itself, especially if the infection, if it's unfortunate, the infection extends deep. This lesion extends itself from the epidermis all the way to the dermis, all right? So you have a lesion that extends itself from the epidermis to the dermis and forms a hole, all right? It forms a hole. And what do we call this? What do we call this whenever we have complete loss of thickness of the epidermis, or really epithelium, and basically penetrating down to another layer, like a dermis, like a basement membrane? What do we call that generally? We call that ulcer. So that's what's happening right here. In eczema or deep impetigo, the clinical presentation may be in the form of a punched out ulcer. So you could have a lesion that in erythema or a deep impetigo, you could have a lesion that extends itself from the epidermis down to the dermis. And this will give the form of a punched out ulcer. So you might see in the hands of a patient or in the lower limb of a patient, you might see the presence of these punched out ulcers. They might be solitary, they might be multiple, and they are the shape of a coin, and they give the appearance of a punched out ulcer, okay, which are surrounded by erythema. You might see these surrounded by erythema, redness throughout, and besides this ulcer, you might think to yourself, okay, this patient might have a case of erythema or deep impetigo. So this is the third and the rarest type of clinical presentation. You might have the presence of a punched out ulcer, especially in the extremities, surrounded by erythema. And what do we mean by punched out ulcer? We mean a lesion in this type of impetigo in which it extends from the epidermis all the way down to the dermis, making this hole. Okay? So this is the third most common type of clinical presentation. It's rare. And remember, out of all of these types, the most common by far is, again, non-bullous impetigo, followed by bullous, followed by erythema. Or another name for it is deep impetigo. Okay? So now we finished the clinical presentation, all right? The clinical presentation of a impetigo, all right? So now the question is, how do I diagnose impetigo, all right? How do I diagnose a case of impetigo? It is very, very easy. Clinical diagnosis, you can tell by the patient, by the lesion itself. I recommend you go to Google right now, search for the 3 types of impetigo in Ambus or anywhere else, and you'll appreciate the difference. You'll appreciate what is the key difference in each of them. So it's by clinical diagnosis. Otherwise, you can take a biopsy or do a swab from the skin lesion, do blood culturing, and you will figure out the causative agent. You'll see this is a bacterial skin infection. Okay? So now, what is the treatment? How do I treat a case of impetigo? Well, typically, a lot of impetigo cases, they can resolve itself spontaneously, but let's say in a case of non-bullous impetigo, if I want, I can give this patient topical antibiotics, all right? I can give this patient any type of topical antibiotics, especially ones of anti-staph penicillin, and we can move on. But if a patient has a case of bullous impetigo, let's say, or a patient has a case of a severe impetigo, let's say like an erythema or whatever, if I have a very, very severe case, right, of bullous impetigo or erythema or a non-bullous impetigo that does not resolve itself, then at this point I can give this patient antibiotics, maybe systemic or topical. But the most important part is whichever antibiotics I give this patient, it's something that has a spectrum against Staph aureus and S. pyogenes, so gram-positive cocci. So I'm thinking of anti-staph penicillin. I can give them diclooxycillin, for example, or oxycillin بشكل عام. Or I can give this patient cephalexin, a first-generation cephalosporin, for example. So I can give one of these two, and besides that, I can also wash the lesion, do warm compresses, all of that stuff. And most importantly, in impetigo, patient education. Please wash your hands, and please, if we're going to give you antibiotics, we're going to give you antibiotics the day before school, especially in a child, so we can prevent the spread of the disease, because it's very, very contagious. Okay? We finished impetigo. Now, which is why the letter I, this is the involvement. Now let's go to the next one. Now let's talk about folliculitis. Now folliculitis is a superficial bacterial infection. From the name, it means localized inflammation of a hair follicle in regards to the epidermis. It means in folliculitis, you have inflammation of a hair follicle, which we said begins from the dermis and extends to the epidermis. So you can have a case of a bacteria like Staph aureus, again, that infects the hair follicle, localized inflammation of this hair follicle, in pertaining to the epidermis. So you have inflammation of the hair follicle, but in the epidermal layer only, and not in the dermal. All right, so we can put here as well F. F for folliculitis. So in the case of folliculitis, here involves pus, unfortunately. This is a purulent infection or a purulent inflammation. All right, and the cause of it is basically the same causative agents that we mentioned from above, like Staph aureus. Staph aureus is by far the most common cause of folliculitis. But there are other bacteria such as Pseudomonas. Pseudomonas, you might find it in a specific type of folliculitis known as hot water folliculitis or a hot bath folliculitis. Basically, Pseudomonas, if some kid or some adult is exposed to contaminated water, then after a day or two, he might have a case of hot water folliculitis, because Pseudomonas, the bacteria, likes to live in water, especially contaminated ones. So if a patient exposed to that type of water, he might develop hot bath folliculitis, which is really self-limiting. It's not as bad as a bacterial folliculitis caused by Staph aureus. And we'll see what we mean by bad later on. But typically in Pseudomonas, it can resolve itself over time. It's self-limiting. But let's focus on the most common type, which is Staph aureus. So the causative agent here is Staph aureus. And you see, what is the clinical feature in folliculitis? This superficial bacterial infection that happens to be purulent. There's pus involved, unlike these two above. The above one was epididymal, there's no pus. There's no involvement of hair follicle, just the epidermal layer, the epidermal cells. But here in folliculitis, there's involvement of a hair follicle, and there's pus involved. So what is the clinical feature? Well, when the Staph aureus and does its job and release the toxins, it will cause inflammation, especially in one hair follicle that is basically involved in the epidermal layer, all right? In the epidermis. And you see, with this inflammation of the hair follicle, it will give rise again to a skin lesion. And the skin lesion that rises here is very simple. Neutrophils will be recruited, and neutrophils, the accumulation of them with edema, with redness, will lead to the rise of pus, right? It will lead to development of pus, accumulation of pus here, all right? So the skin lesion that represents the clinical presentation of folliculitis will be in the form of an itchy, tender, red, edematous papule or pustule, raised lesions that have erythema surrounding it, all right? That is the clinical presentation of folliculitis. And you might have this cutaneous manifestation with or without, again, systemic symptoms. Patient may come with fever, with leukocytosis, with lymphadenopathy, with malaise, chills, and so forth, depending. Now, of course, this is what the skin lesion looks like in folliculitis. If you look at a picture of a child or in a young adult, you will see in folliculitis, this is the skin lesion right here, all right? So the skin lesion can be in the form of a papule or a pustule. The pustule is the same as a papule, but it's filled with pus, okay? So basically here, you can see in this red color, this is the erythema. You might see in the extremities, all right, any hair follicle here or any hair follicle in any place in your body might be infected by Staph aureus. So you might see in their skin or surrounding the skin lesion is erythema. You might see erythema in the background. And at the center of this erythema is pus. You might see pus in the purple color that's leaking out here. And it so happens that this pus, which we all join up together to be pustule, this pustule here, which is basically a raised lesion consisting of pus, this pustule that is surrounded by erythema, this is located at the site of the hair follicle, meaning this, you might see a hair follicle coming out like this. So if you see this skin lesion, you might think this is a case of folliculitis. This hair follicle is infected, this hair follicle is inflamed, and it is characterized by a pustule, a raised lesion consisting of pus, especially in the purple color, surrounded by erythema in the background. It could be solitary, it could be multiple hair follicles being inflamed, okay? This is the clinical presentation of folliculitis. It may present as a papule or eventually accumulate with pus and becomes a pustule, all right? A raised lesion with erythema at the center involving a hair follicle that's being affected. Now, the thing about folliculitis is that folliculitis, the treatment is kind of simple, all right? The treatment for folliculitis is very simple. You can diagnose it by clinical diagnosis, the same, take a swab if you want, but it's really enough with clinical diagnosis. And you can treat it typically with washing of this lesion. If you see this lesion, especially in the arms, you could first, as a first-line therapy, wash this lesion with antibacterial soap and water 3 times a day. All right, and see with time it will resolve itself. So typically you start with treatment by the letter C, you'll do cleaning. You will do hand wash and cleaning for this lesion with antibacterial soap for 3 times a day, and eventually it can disappear. But if it doesn't disappear, if it's not working as well, you can give this patient AB, antibiotics. And here typically you can give this patient topical antibiotics, all right? You can start with any topical antibiotics and give it to the patient, especially an anti-staph penicillin, which can resolve this issue clearly, all right? So you can do that as well. Of course, the thing we are really afraid of folliculitis is that it really can be easily treated and easily detected, and inshallah, you'll not prevent complications, or inshallah you will prevent complications of folliculitis from occurring. Because what is dangerous about folliculitis is not necessarily the clinical presentation of folliculitis. It's fine, it's a purulent infection, it's fine for the hair follicle, that we can treat it. But the complications of folliculitis, that is the most dangerous part. You see, what happens in folliculitis is that if we leave this lesion, all right, if we leave this infection untreated, all right, you see the edema and the pus specifically, the infection, it can eventually spread, all right? It can eventually spread from the epidermis down to the dermis and infect the hair follicle at the level of the dermis as well. And if that happens, then neutrophils will follow, infection will follow, inflammation will follow, and this will lead to accumulation of pus surrounding this affected follicle, all right? So you can have multiple pus being collected here in the form of an abscess, all right? So you might have, in this case, abscess here as a complication of folliculitis, and which, if you don't treat folliculitis, then the infection can basically extend from the epidermis to the dermis, affecting this hair follicle with accumulation of pus. And this accumulation of pus in the dermal layer, in the dermis now, in the dermis layer, or any layer within it down below, like subcutaneous, they call this in skin infections as an abscess. And if you have an abscess, especially in this case, perifollicular abscess, then this is a bad thing. Here in this case, you need to treat this patient immediately. All right, and typically this happens in people that neglect treatment or in people that are immunodeficient, like diabetic patients. All right, so that's when you suspect why that might be the cause. So the complications of folliculitis is perifollicular abscess. All right, and they have a term for it, and this term for it is basically known as deep folliculitis or furuncle, or another word for it, boils. So boils or furuncles is a type of deep folliculitis in which you have an abscess, or specifically perifollicular abscess, as a result of extension of the infection from the epidermis to the dermal layer, leading to the formation of pus here, and this formation of pus will lead to an abscess. And of course, if you have an abscess here, then the clinical presentation from the outside will be different. It means that the skin lesion here from the outside will look different in furuncle. What do I mean by that? Well, in folliculitis, initially, you had the case of a pustule, a very simple pustule, or a pus, or a papule, or a pustule that basically has a hair coming out of it. That is the hair that's being affected, and it was surrounded by the red color, which was erythema. But in the case of furuncle or boils, what they look like from the outside is in the form of a deep infection, or let's say a deep infection, especially in the epidermis, that from the outside appears as a painful erythematous nodule. So the clinical presentation of an abscess, especially in the case of furuncle, will appear as a painful erythematous nodule, like this one right here. So if you look at the extremities or any place in the body, a furuncle or a boil will appear as a nodule. And if you don't remember what a nodule, it's a raised lesion in which the nodule is raised, but it's deep. Meaning that this nodule, it basically looks like this. The depth is greater than its diameter because you have accumulation of pus here, and this pus accumulates up and goes up and up and up and up. So the depth of it is greater than the diameter. They consider it as a nodule. It's a raised deep lesion. And that is the characteristic feature of a furuncle. You have a painful erythematous nodule that at some point may lead to rupture, or at some point it may lead to drainage of pus from the outside. And the drainage of pus can be one thing. So you can imagine this drawing right here, this red color right here, this is the nodule, all right? And this nodule at some point may lead to drainage of pus. Because as we said, this nodule in the case of furuncle consists of pus. It consists of abscess, okay? So at some point, this abscess can lead to pus drainage, a single pus drainage, which is characterized by the color purple, all right? So if you see this case, especially in a bigger diameter in size as compared to pustule in folliculitis, you might think to yourself, this is a case of furuncle, all right? So the clinical presentation of a furuncle or boil is a painful erythematous nodule or pustule that increases in size slightly, and there is one pus drainage coming out of it. There is a single pus drainage that's coming out of it because at this point, only one hair follicle is being infected completely, okay? So this is a furuncle, a type of abscess as a complication of folliculitis. But let's say we have more than one hair follicle being infected. Let's say, for example, we have another hair follicle here, all right? And let's say this hair follicle also has the same issue. Let's say we have another furuncle, the same issue. Now we have another furuncle here, all right? Another boil, another hair follicle being infected here as well. And let's say all this accumulation of pus between the follicles, they join together, all right? Now you see, this pus right here in this hair follicle and the pus surrounding this hair follicle in this one as well, they may coalesce with one another. The pus collection here in the blue, they may join together to form a very big inflammatory subcutaneous mass. And this inflammatory subcutaneous mass, this coagulation, this joining of one boil, of one furuncle to another, is known as carbuncle. So a furuncle, or let's go to the beginning. If a folliculitis is left untreated, it can develop into furuncle, a painful erythematous nodule. But if this furuncle is left untreated, it will lead to development of carbuncle. Okay? So in carbuncle, you have the same thing. You'll have a painful erythematous nodule, but if you look at this drawing compared to this drawing, the nodule in carbuncle, it's much larger than this one, right? Because now the abscess have joined up together to become bigger in mass, especially in the dermis and subcutaneous layer, all right? So they become bigger. And not only that, you have multiple furuncle. So you have a furuncle affecting this one, and you have another furuncle, and they join together. So what happens in carbuncle, you have a very big nodule that have multiple pus drainage. So you see this purple color, you have a pus drainage coming out. There's a drainage of pus in this area. There's a drainage of pus. And each pus drainage represents a different furuncle that joined up together. So this furuncle, this is draining pus from one furuncle. This is draining pus from a second furuncle. This one, and this one, and this one, and this one. This big abscess, this big pus that's draining out of this carbuncle, this big mass of abscess. All of this represents a carbuncle, which is, again, a painful erythematous nodules with multiple pus drainage or multiple sinus drainage. And this gives the appearance of a sieve. A sieve is basically something that's used in the kitchen. If you look up in Google the term sieve, S-I-E-V-E, you'll see it basically looks like this, like a pan with multiple openings. So that's what a carbuncle resembles like. It is a very big, painful erythematous nodule with multiple pus drainage. But in furuncle, you might have a painful erythematous nodule that's much smaller with a singular pus drainage. Okay? So look at pictures of a furuncle and carbuncle, and you will completely appreciate the difference between the two. So that's what's going on here. And typically for these two, carbuncle and furuncles, these two types of abscess that are seen as complications of untreated folliculitis, these two are most commonly seen affecting the hair follicles that are prone to friction. Yani, for example, the hair follicles in your glutes, the hair follicles in your back of your neck, those hair follicles that are prone to friction, those are the ones that are most predisposed to the development of a furuncle or carbuncle. So you might see in a lot of pictures of carbuncle, you might see a carbuncle in a patient's glutes. That's not a coincidence. So you might see these deep infections or these deep abscesses. You might see them in the back. You might see them in the back, or in the back of the neck, or in the glutes. Any hair follicle that contains or is susceptible to friction. Okay? And that's pretty much it. Of course, what is the treatment in that case, Nawaf? What is the treatment for furuncles and carbuncles? What do I do in this case? Well, in this case, in case of furuncles, if it's a small one, you can do warm compresses. You can give this patient warm compresses and it will ease in its drainage. However, if you have a case of a carbuncle, or if you have a case of a furuncle that's large, then no. In this case, as a principle, any case of abscess, especially large, you will do what? D, the letter D, incision and drainage, okay? You will do incision and you will drain the abscess, because if you don't drain this abscess, then the bacteria that resides within this abscess, it will still be there and it will continue to cause infection over and over and over again. So I need to get rid of this abscess via incision and drainage, all right? So I can get rid of the bacteria that resides in it, all right? So that's the main treatment in case of carbuncle and in case of a large furuncle. If it's a small furuncle, I can try to give warm compresses. Alright? And we already talked a bit about the treatment of folliculitis. So, regarding the treatment of folliculitis, A, B, C, D. A, B stands for antibiotics. C stands for cleaning, hand washing the lesion with antibacterial soap and water. And D stands for drainage in case of abscesses. Abscesses that may be seen in furuncle and carbuncle if left untreated in the case of folliculitis, or if you have a patient with weak immune system. Okay? That's pretty much it, of course. And of course, with furuncle, carbuncle, you could give this patient antibiotics. Typically, with incision and drainage, or when you do dressing, you also give this patient antibiotics as well that are really prone to Staph aureus, anti-Staph penicillin, that will get rid of the infection as well. So now that we finished the superficial bacterial infection, now we can go to the deep. Now we have finished the superficial bacterial infections, the impetigo as well as the folliculitis, okay? Now let's talk about basically here, and let's draw here for example, or let's not draw here, it's basically part of it, but let's put here as well F for furuncle, and here C to represent the F and the C with the F here. These all together, folliculitis, furuncle, and carbuncle, they represent the sites that are being affected. And the F, that's folliculitis in the epidermis. The furuncle and carbuncle in the dermis. Okay? Alright. Now let's talk about deep bacterial infections. Alright? Let's not forget, any clinical presentation I usually mention, you can think of this one. This is a concept. This is what all of them usually represent. The lesion is the difference. Is it a basically vesicle? Is it a bulla? Is it a case of a pustule? Depending. Okay? Alright, now let's talk about let's talk about deep bacterial infections. Now the term deep means now we're talking about bacterial infections that occur in the dermis, alright? Dermis and below. So dermis, subcutaneous layer, fascia, and skeletal muscle. So let's talk about the deep bacterial infections. اللي هما erysipelas, cellulitis, and finally necrotizing fasciitis. Now, let's talk about erysipelas and cellulitis, alright? Now, here's the thing. When I talk about these two conditions, they're very, very similar, alright? Both of them are very similar. But the difference is in their clinical presentation and their causative agents. So let's talk about erysipelas and cellulitis together. What is the difference between the two? Well, to start with, both of them are deep bacterial infections that basically involve the dermis. The key difference to start with is in the case of erysipelas, they consider it as superficial cellulitis. From the term, it gives clinical presentations similar to cellulitis, but erysipelas involves the superficial part of the dermis. So with the green color here, I will put the term E. Alright? So we'll include the superficial part of the dermis, and as well as lymphatic vessels of the skin. That's what erysipelas is. It's a deep bacterial infection, most commonly group A streptococcus, okay, like Streptococcus pyogenes, in which it involves the superficial part of the dermis and the lymphatic vessels of your skin. So typically when you see later on in the clinical presentation, you might see the presence of lymphangitis. It might involve infection of the lymphatic vessels, and you might see red streaks. Those red streaks would represent the lymphatic vessels as actually being infected in erysipelas. Okay? That's why they also call erysipelas superficial cellulitis from the origin. Okay? So regarding erysipelas, the causative agent most commonly is group A streptococcus. But what about cellulitis? In the case of cellulitis, the most common causative agent in it is aureus, Staph aureus. So here, in case of cellulitis, the common causative agent can be Staph aureus. And in the case of cellulitis, it's not superficial, it is deep. Don't confuse erysipelas. Erysipelas is a deep, but it is superficial. The infection is superficial in comparison to the cellulitis, okay? So in the case of cellulitis, you have an infection, a deep bacterial infection that now involves here in the deep dermis, okay? So we're going to put the term C, cellulitis. Cellulitis involves the deep dermis, but the erysipelas, which is termed superficial cellulitis, involves the superficial dermis as well as the lymphatic vessels of the skin. Okay? So now that we got that out of the way and we know the causative agent most commonly between the two, all right, now let's talk about the difference in their clinical presentation. Now, first of all, the difference in their clinical presentation is just very, very simply in the margins. And let's see that. You see this lesion right here? This is the primary skin lesion that occurs due to infection in the dermis. It will lead to a pathological change in the skin, and it will lead to the development of a skin lesion. Now, in the case of both erysipelas and cellulitis, there will be erythema, all right? Because you see, in the dermis, whenever there's infection in this area, comes the immune system, and the immune system will lead to what? Edema and redness and everything we've mentioned. Itching, tender, edematous, and all that stuff. But especially, since in this dermis layer, when it's infected, it will lead to the development of edema. So much edema that the skin will be raised. So you will have a raised skin lesion that appears like a plaque. Alright? And if you don't know what a plaque, it's a raised lesion more than 1 cm. So what you have here, these two red coloring drawings, these are two plaques that are very, very reddish, erythematous. By the color black, they are very erythematous plaque and edematous. Alright? Because remember, the dermis involves a lot of blood vessels. That's where the blood vessels are located in the dermis, V-A-N. VA for artery and veins, and N for nerves. So whenever you have an infection in this area, there will be a lot of edema, there will be a lot of blood that's being pushed, vasodilation, and thus you'll have a raised skin lesion in the form of a plaque that is red, erythematous, and edematous. Okay? Now, this is in the case of erysipelas and cellulitis. But what is the specific difference? Well, in erysipelas, the plaque here tends to occur mostly in the face. So if you look at a picture of erysipelas, you'll see most patients, they have a very reddish and edematous plaque, especially in the face. Here in the cheek, for example, or in the back of the ear, anywhere in the face mostly, okay? While in the case of cellulitis, they tend to have a reddish edematous plaque that mostly occurs in either lower limb. So cellulitis patients may have the plaque, this reddish edematous plaque, either in the red leg or in the left lower leg. So in the right lower leg or in the left lower leg, one of the two. So that is the one key difference, is that these lesions, according to the site, in erysipelas, mostly in the face, in cellulitis, mostly in either of the two lower limb. Not just that, the second key difference in their clinical presentation is the borders. In erysipelas, the borders are very, very, very well demarcated, meaning you can imagine it like a square. I can see the border here in comparison to the skin surrounding it. I can see this border, I can see this border, I can see this border, and this one, like a rectangle. But in the case of cellulitis, no, the border is poorly defined. It is ill-defined, all right, like these. So it's ill-defined, it's spread throughout, okay? So in the case of erysipelas, the borders are well demarcated. It may look localized, this plaque, this lesion may look localized, but in the case of cellulitis, you cannot determine the margins. So it appears the lesion in cellulitis as diffuse, a diffuse lesion with irregular margins. You cannot determine it. So that is the key difference between cellulitis and erysipelas in clinical presentation. Again, up to this point, the difference between the two is that the causative agent most commonly, the gas for erysipelas, the Staph aureus with cellulitis. Besides that, the erysipelas is also known as superficial cellulitis, in which it involves the superficial dermis as well as the lymphatic vessels, and specifically the lymphatic vessels of the skin. So erysipelas may present with this plaque along with lymphangitis, meaning a red streaky pattern all over the arm, representing the lymphatic vessel that's actually being inflamed here, okay? And it may infect the lymph node. You might have lymphangitis. That's only seen most commonly in erysipelas. Meanwhile, in cellulitis, you have this plaque that is basically like erysipelas, and it involves the deep dermis. It is a deep case of cellulitis. And the plaque in cellulitis is ill-defined and it's diffuse, especially in either lower limb. But in erysipelas, you have this plaque, but it's well-defined and is red and edematous, that's seen most commonly in the face, along with lymphangitis and lymphangitis. Okay? That's pretty much it. Now, the treatment for both of them is typically antibiotics. You have to give this patient empirical antibiotic therapy, okay? That's important, because in case of cellulitis and erysipelas, we treat it as a serious case. You have to treat it in the form of empirical antibiotics, broad spectrum antibiotics, with elevation of the affected site. Like in the example of cellulitis, if I have cellulitis of the right lower limb, I will give this patient antibiotics, empirical IV systemic, or let's say systemic antibiotics, let's say IV, and I'll tell the patient to elevate his right limb that is being affected. Why do I elevate the right lower limb, for example? Because that right lower limb will be filled with swelling. It will be filled with edema. So if I elevate it, I can relieve the swelling and I can promote healing. So that's the idea with elevation, especially in cellulitis, where if I elevate the site that's being affected in cellulitis or erysipelas, I will relieve the swelling by gravity and I will promote healing. Okay? So in both of them, I will give empiric antibiotics with elevation of the affected site. Okay? We have now finished both of these two and their differences. And again, I need you to look at pictures of both of these to appreciate the difference. Okay? Now let's talk about the final bacterial infection, and that is necrotizing fasciitis. Now up to this point, everything I've mentioned is kind of connected together in their concept. Most of these bacterial infections, most of them have itchy, tender, red edematous, and edematous skin lesion, according to the skin lesion, with or without fever and systemic symptoms. But in the case of necrotizing fasciitis, this is a very, very bad case. You see, in necrotizing fasciitis, from the name, it means inflammation or infection that involves the fascia and the skeletal muscles, okay? So you have a case of a staphylococcus infection or streptococcus, let's say a group A streptococcus infection, a gas infection, or Staphylococcus pyogenes infection. And unfortunately, this infection occurs at the site of the subcutaneous layer, or at the site of the fascia, especially the superficial and the deep fascia, as well as the skeletal muscle. And this infection leads to inflammation. With inflammation over time, it will lead to rapid development of necrosis. And this necrosis is very bad because this means we have a lot of dead cells. Alright, and a lot of dead cells is bad because necrosis can lead to gangrene. And you have gangrene, especially in the case of necrotizing fasciitis and an affected limb. At some point, this can lead to septicemia, and septicemia will lead to the death of the patient due to multi-organ failure. So necrotizing fasciitis basically means that you have a case of an infection at the level of the fascia, superficial fascia and the deep fascia and the skeletal muscle. You have an infection there that leads to inflammation, and with inflammation leads to rapidly progressive necrosis of these affected sites that can lead to gangrene and septicemia and eventual death. So necrotizing fasciitis is a deep bacterial infection that's very, very, very severe. It is an emergency. It is a surgical and a medical emergency. You have to treat it immediately once diagnosed. So, what is the problem with necrotizing fasciitis? NF, right here. This is the affected site. What is the problem with necrotizing fasciitis? We already mentioned before. But what is the clinical presentation of necrotizing fasciitis? Well, in necrotizing fasciitis, really the clinical presentation and really the problem with necrotizing fasciitis is that it might appear initially as a case of cellulitis. The patient, he might come to you as a case of cellulitis. You might see in this patient, he tells you he suffers from very, very severe pain. Very severe pain in his right lower limb. So much pain, and you look at his right lower limb and you'll see a case of erythema, right? You'll see the case of this lesion right here, an erythematous edematous plaque, right? And you think, okay, this might be a case of cellulitis. But this patient is complaining of so much pain out of proportion, all right? And this patient also tends to have delirium. This patient starts to be delirium. He starts to be, and he's not able to cooperate completely. He tends to be dazzy. He tends to have dizziness. So he has altered mental status. And you're thinking to yourself, what's going on here? And then once, let's say, for example, you misdiagnose the case. You just give this patient antibiotics. He comes to you maybe like 3 days later, and then he comes to you with this skin lesion. He comes to you with a plaque that's not red anymore. No, it's now dusky colored. You have a dusky, gray colored edematous plaque that's covered all over the right lower limb, and it is very, very foul smelling, very hideous smell, then you have entered in this case an emergency case of necrotizing fasciitis, okay? Why did I mention all this? I mentioned that necrotizing fasciitis does not necessarily come with a patient in a case of this gangrene, for example. The patient may not come to you with this dusky gray colored plaque that's all over the right lower limb. No, this patient may come to you in a presentation similar to cellulitis, but with severe pain, that if you don't think about it, if you neglect it, if you don't think of necrotizing fasciitis as a possibility, eventually what happens is that it can eventually lead to the characteristic feature of necrotizing fasciitis, which is a dusky, gray-colored edematous lesion or a plaque with irregular borders covering the entire right lower limb. So let's ask ourselves the question, why? Why does necrotizing fasciitis not present with this lesion immediately, this black-colored lesion? That's because in necrotizing fasciitis, the infection first appears in the dermal layer, all right? It first appears not at the dermal layer, it appears down below. It appears at the deep layer of the skin. It appears in the deep layer of the skin. Then eventually with time, it will go up. The infection will start to go up and up and up. So basically, the necrotizing fasciitis, the problem starts at the down below, at the very, very deep, at the deep end. And so in the deep layer of the skin. So if it starts in the deep layer of the skin, it might give the presentation of cellulitis. But eventually, with over time, it will involve the superficial layers as well, going up and up and up. And eventually, it will give the presentation of necrosis, definitely necrosis, dead cells that will appear very, very, very prominently in the form of dusky gray colored lesion. Okay, so that's why it might appear as red edematous lesion that eventually develops into a gray dusky colored lesion that's edematous. It was irregular and huge. Okay, of course, on examination, in case of necrotizing fasciitis, on examination, you can see in this patient the smell is very bad. I remember in a hospital I had a case of a patient with necrotizing fasciitis. The smell was very bad, all right? And not just that, when you touch the lesion, when you touch it right here, you'll feel a gas, all right? And you can do this early on, even early on in necrotizing fasciitis. You can touch the lesion and you will feel a gas here. There's like a palpable gas. You can feel the sound of a gas, right? Like a Pepsi. And this gas is known as crepitus. And this is also a sign of necrotizing fasciitis. Crepitus occurs in necrotizing fasciitis because the bacteria here, like group A Streptococcus, gas infection, a lot of Streptococcus pyogenes, they produce a toxin which acts as a gas. They produce gases. So you might see a lot of gases in this lesion that if you palpate, you'll feel a gas. Like this, a crepitus. And this is also a sign of necrotizing fasciitis, okay? And also another sign of necrotizing fasciitis, especially in late cases, of course, when we have a lot of dead cells, especially in regions like in the dermis at this point, where the nerves are affected, at some point there might be anesthesia in the site, meaning patients may not complain of pain. Maybe this patient complained of severe pain, you gave him basic antibiotics, you think this patient's resolved, now he comes to you with this lesion and he didn't feel it. That's because the lesion, like we said, it progressed to such a late stage to the point that it affected the nerves. So there is no nerve sensation here. There is complete anesthesia, right? So the patient may not feel any pain, but there's definitely a case of necrosis that eventually leads to development of gangrene, and that's very, very bad, okay? So this is the clinical presentation of necrotizing fasciitis. All the story I mentioned is very important because necrotizing fasciitis, this is not something you can just treat with antibiotics and that's it. No, this is a medical and surgical emergency. The mortality rate can be up to 20% if left untreated, all right? So in the case of necrotizing fasciitis, the diagnosis here is صراحة clinical diagnosis and with history and with biopsy if need be, but typically besides clinical diagnosis, the one way to diagnose for necrotizing fasciitis is really you do debridement, okay? You have to do debridement for this patient. Basically, let's say we have a case of necrotizing fasciitis, or I'm suspecting necrotizing fasciitis. This is an emergency case, remember, mortality rate up to 20%. So if I'm suspecting necrotizing fasciitis, the first thing I will do is consult for surgery. I must do consultation for surgery and say, I want to do surgery for this patient. I want to do debridement for this patient. That will be both diagnostic and therapeutic. I will discover very, very quickly if this is a case of necrotizing fasciitis. And if it is, I have to do extensive debridement. Extensive debridement, especially if it's at the lower lip, like let's say at the thighs, I have to do extensive debridement with broad spectrum antibiotics given together. Alright, so I have to do extensive debridement, remove all this dead tissue, and I have to give broad spectrum antibiotics IV. And then I have to constantly monitor the patient to make sure that necrotizing fasciitis does not develop eventually to gangrene, because gangrene can lead to amputation of the lower limb, and we have to do amputation of the lower limb because it will eventually lead to septicemia and to death from multi-organ failure. Okay, so the first line treatment, if I'm suspecting necrotizing fasciitis, I have to consult for surgery. And once I consult with the surgeons that I want to do surgery, it might be a case of necrotizing fasciitis, we do it in the form of debridement, extensive, and we give this patient at the same time broad spectrum antibiotics, and then we'll see from there how the patient does moving on. Okay? That's it. That's pretty much it for necrotizing fasciitis, another deep bacterial infection. Okay? That's pretty much it for the bacterial infections, and I hope you enjoyed. Remember the superficial bacterial infections as well as the deep bacterial infections. We have two over here for superficial, impetigo and folliculitis, and we also have a case of deep bacterial infections in form of erysipelas and cellulitis, as well as necrotizing fasciitis. That's pretty much it. Thank you.